Hello, everybody. Welcome to this Semanos Campus web seminar for professionals. My name is Marcio Garcia dos Santos. I'm part of BEGO Implant Systems Education and Clinical Research team, and I will be the moderator of today's session. First of all, I hope that you and your family are all in good health. And before introducing our speaker, I would like to thank Mrs. Angelica Jacob from BEGO's Global Marketing Department for the organization of this session. The topic today will be soft tissue treatment in the aesthetic region, and the speaker will be Dr. Matej Kulis from Slovenia. Dr. Kulis finished his dentistry studies in 2013 as one of the best students in his class at the School of Dental Medicine, University of Zagreb, Croatia, and since then he works as an implantologist and prosthodontics in private clinic. In 2018, he received the title of prosthodontic specialist at the University of Zagreb in Croatia and is currently finishing the program for oral implantology master degree of science also at the University of Zagreb. Since 2016, he lectures at courses in congresses and courses in Congress in several countries. What I can say, he's a passionate for the profession. He makes fantastic documentation of his clinical cases, and for sure, he's one of the biggest names of the new speakers generation. Matej, my friend, thanks for accepting the invitation to conduct this section. As always, at the end of the lecture, we will have a question and answer session with the speaker, and you can place your questions in the question box during the whole presentation. Wishing us all a very nice time, I give the words to Dr. Kulis.
Thank you, BEGO Implant System, for inviting me to presenting one of my favorite topic. Thank you, Marcio, for a nice introduction. Hello, my dear colleagues. Today I will talk about my perfect topic, soft tissue treatment in the aesthetic region. Nowadays, everybody of us, we want to gain natural shape of the emergence profile. This is our goal in every type of implantology. Natural appearance of restoration. Why? Today, patients become more and more demanding about aesthetic results when replacing missing tooth with implants. The current trend is shifting from merely restoring the loss of the function to complete restoring, with which we want to achieve natural appearance of our restoration on implants. Before I start, I would like to introduce myself. I'm Matej Kulis. As Marcio said, I'm coming from one of the beautiest city in Europe, Ljubljana, capital city of Slovenia, and we gain right now the title of the greenest capital city of the Europe, and one of the think it is one of the top visitor places. So it is very nice to visit this beautiful city. It is one of the smallest capital city in European Union. Okay, so pink aesthetic is one of the very important factor for a complete success in a restorative dental treatment. However, gingival architecture, referred as the pink aesthetic, is also one very important factor for a success. There are many different procedures to perform and to gain perfect soft tissue results, but the biggest problem is because many times this procedure is performed separately and prosthetic procedures was done after soft tissue treatment. So, in my opinion, it is desirable to perform procedure simultaneously. Prosthetic components and soft tissue management should be performed simultaneously. The prosthetic components should be shaped properly and applied at the right time, during the soft tissue manipulations, and immediately before the healing starts. So before we start with soft tissue management, I would like to say something about implant supracrestal complex. We know that we have a connective tissue zone, junctional epithelium zone, and sulcular epithelium zone. All these zones belongs to the prosthetic zones like C zone, B zone, and A zone. Why is this very important? Because in every of these zones, it is very important to have a typical shape of emergence profile. In C zone, it is very important to going straight. In a B zone, depend on the implant position and soft tissue managements, it could be convex or concave, and E zone, which is very important to support soft tissue. This is critical zone, which is very important for final aesthetics results. B zone is the most variable part. If we're performing soft tissue procedures, then we should properly shape this zone. If we don't using connecting tissue grafts, then we need to fill this space with convex design. If we're using the connective tissue graft, then we should leave the space for a connective tissue graft, and this shape is, in most of the cases, it is concave. One of the important factors to gain perfect results in aesthetic regions is also implant positioning. We should place implants a little bit more orally, because we need the space for prosthetic components, and this is very important to achieve optimal soft tissue thickness. Small mistakes could be corrected, but biggest mistakes is if we position our implants too much buccally, which is very dangerous and could produce the recession. And here is the question: do we need the soft tissue management, soft tissue treatment? Okay, this is the question always we think. Here is the one example. Here we have a different procedures, different technique to preserve soft tissue volume and hard tissue volume, but we have a very similar results. Here is one case where I perform immediate implant placement with a surgical guide, and I also applied immediate provisional. Do we need this? Okay, here is the technique. I fill the bone gap with a xenograft material and immediately apply the provisional. Here is the results after 12 weeks. We get a perfect soft tissue. Okay. Do we need soft tissue management? If we read the article of Dennis Tarnow, this is the bilayer zone, dual zone technique, where they apply immediately provisional restoration and fill the gap with xenograft or allograft material, they get a very good results. Also, here is another paper from Francesco Amato, which also apply immediately provisional and get very small recession, which is 0.04 millimeters without recession. So what is the soft tissue management? Soft tissue management, soft tissue treatment starts with the provisional. And this is why these dual zone therapeutic concepts have a very good results. Where this starts? So soft tissue management starts with the soft tissue support. Soft tissue support is one of the most important factors to get the perfect results in aesthetic regions. This gives the support for a free gingival margin. So soft tissue management starts with the optimal soft tissue supports. Even if we use the connective tissue grafts, we still should perform this cervical contour, which will enable support of the soft tissue and retain the gingival margin at the right position. If we use connective tissue graft, then as I said, we need to perform the space in a B zone. This is not only for immediate implant placement important, also when we performing two-stage procedures. Here we have one example when I perform guided bone regeneration, and then we have here the second stage. I apply the prosthetic components which is properly shaped, like the final prosthetic restoration, apply connective tissue graft, and this part here is the most important. This gives me the soft tissue important. And connective tissue graft. Why connective tissue graft? Because connective tissue graft minimize the risk of recession, which is the biggest problem in aesthetic region. If we read the paper from Uli Grunder, we found that sites on which was performed the connective tissue graft didn't have any aesthetic complications. So connective tissue graft prevent recession. But here is one my cases with the long-term results. We perform immediate implant placement at this site. We extract this premolar. Here we perform guided bone regeneration and FDP unit. How we start? We play immediate implant, tape two sockets. We apply immediately implant, harvesting connective tissue graft, application of connective tissue graft, fill the gap with dentin graft and membrane applications. And here is also very important prosthetic component, which is properly shaped. In this case, the buccal part of custom healing abutment, I a little bit lower it below the gingival margin, which enable me to get the overgrowth of gingiva, which also a little bit increase the height of the gingiva. And here is the final result before the application of final restoration. And here we have a follow-up immediately 3 months after final restoration, and one year. We have a perfect results, stable results, and here is the follow-up of 2.5 years after hygienic treatment, where we have a very nice soft tissue and have a stable results. And if we compare with this 3 months after finishing and 2.5 years, we see that we have a very slight recession, but that is not important. We get a perfect aesthetic results, and this is why I like to perform connective tissue grafting in aesthetic region. And here is the complete case where we get a perfect emergence profiles and stable soft tissue results. Which connective tissue graft? Epithelialized tissue connective tissue grafts is only restricted to the cases where it's an increase in keratinized tissue is needed. We cannot perform epithelialized graft in aesthetic regions because we have aesthetic complications. Connective tissue graft without epithelium is our goal, but removal does not exceed more than 2 millimeters, because below the 2 millimeters we have a glandular or adipose tissue, and first 2 millimeters is very rich with connective tissue, collagen fibers, which is very important to increase the thickness and enable stable long-term results. And place where we harvesting, if you read the papers, the perfect site is between the first molar to the distal part of the canine. In this part between the canine and first molar, we have a more adipose tissue. Distally, from the first molar, we have a more glandular tissue. And where is the optimal part? The optimal part is 2 millimeters from the gingival margin, and this is the 5 to 8 millimeters their safety zone to the greater palatine artery. This is the most sweet spot for harvesting of connective tissue graft if we're reading the papers. 8 millimeters, it is safety zone. The sharp part of the 15C blade is 8 millimeters, and we can help with scalpel blade to know how much is 8 millimeters. Tuberosity is also very perfect donor area. Why? Because connective tissue graft from tuberosity is very dense, it is rich in collagen fibers and have a very little glandular or no glandular or adipose tissue, and also have a perfect color matching. But this connective tissue very like to hypertrophy, producing not so good aesthetic results, because it is like to producing the hypertrophy of connective tissue. There is a different technique how to harvesting. Here is the single incision technique. Single incision technique, where we perform one incision and harvest the connective tissue graft. With this technique, we get a little bit more thicker connective tissue graft, but we goes deeper and we get a not so perfect connective tissue graft, which have a lot of more glandular or adipose tissue. And in many cases, we harvest too deeply, and in many cases, we also harvest the periosteum. Deepitalize free gingival graft, also very good technique, where we remove only 2 millimeters of surface of plate of the donor tissue. And how to deepitalize? I like one technique. I like technique where I use the burr. Here is the example where I deepitalize. We know when it's deepitalized because starts bleeding, where is epitalized don't bleeding, and I using this circular diamond burr, which is perfect to remove epithelium. Very simple technique. And if you saw, I like very much to harvest connective tissue graft very distally. Here is around the second premolar and third second molar and third molar, because this area, in my opinion, is more rich with the collagen fibers than the region between the canine and first molar, even though the papers say different. This is my opinion. It is not approved with the papers. But with connective tissue graft, we get a morbidity. Zucchelli in paper present there is no difference between the single incision and free gingival graft technique for harvesting. If we compare why this with single incision, in many cases we go too deeply because it is very difficult to separate only epithelium. In the most of the cases, if we only separate the epithelium, we get a necrosis also, not big necrosis, but small necrosis, and we also will get the contraction of soft tissue. With the epithelialized soft tissue graft, we harvest more superficial parts, which then healing with secondary intention, and we leave also the part of connective tissue and periosteum. So if we look the studies, there is no difference in morbidity, and I prefer more the technique of free gingival graft technique for harvesting, because I get a better connective tissue. And here is my one cases. I performing both techniques, single incision and free gingival, but in my opinion, in my hands, I more prefer free gingival. Here is the healing. I took the print screen and you can see results. In many cases, on some part, it is too thin and we have problems with the healing, as I said, with the retraction of the soft tissue. And here is the healing of free gingival graft technique harvesting, where we get a perfect secondary intention healing. Here is after 9 days, we get a completely healing without any pain and without any compliance from the patient side. And here is the cases how I performing soft tissue management procedures in aesthetic regions. And we will start with the one cases where I perform first socket preservation and then delayed implant placement. Here is the case. We have a fractured left central incisors. Before that, the central incisors was restored with fiber reinforced composite post, and this broken, and this crown become movable. We have also very not perfect position of these central incisors, which have a very protrude position. And how we start? I remove this fractured crown. I lowered this part of the retained root below the gingival margin. I removed all the crown from the left second incisor, and I apply the direct provisional. And why I lower this part of retained tooth? Because I want to get with provisional get the perfect support, this first millimeter support of the soft tissue, which is very important for aesthetic. After that, I perform the extraction. There is the perfect socket step 1, where we have the buccal bone. I extract also the wisdom tooth, third molar, and make the autologous dentin graft, apply in a socket, apply membrane, harvest connective tissue graft, and apply it in tunnel, which I prepared. Tunnel is prepared between the buccal bone, and it is split thickness soft tissue tunnel. I said this technique, I have my name, triple zone concept. Dennis have Tarnow have a dual zone concept. This is my triple zone concept. That's mean preservation of the buccal bone, connective tissue graft application, and of course immediate provisional to enable the soft tissue support. And here we apply suspended suture to move the graft, to move the flap coronally. And here is the healing. After 3 weeks, we get the perfect soft tissue results. And here is the after 2.5 months. And then we start with here is the results from occlusal side. We see that we get retained the buccal volume of lost central incisor, but after 4 months we get a slight decrease. Even though that we perform connective tissue graft, we get a slight decrease in volume. And now is the time to place the implant. I make the surgical guide. It is very important to create sufficient place for a implant supracrestal complex, very important part. And I start with the guide. I checking the position, prosthetically position with the analog technique, with the implant positioner posts, and application of implant 1 millimeter below the bone. If you see application of temporary abutment connected, and then I prepare the tunnel, apply connective tissue graft, apply the connective tissue graft in tunnel, and here is the result where I increase the buccal volume. And here we have a donor area. It is from a free gingival graft, very distally, and application of sutures. And here is the results before the removing the sutures, and 10 days and after 1 month we get the perfect results. We retain the volume, we reshape, we get back this volume of the proper central incisor with connective tissue graft and application of the provisional. And here I will finish this case and start with the new, because after that I start with the prosthetic procedures, and this I will present within one other webinar or on one other congress, because we don't have a sufficient time to talk about the soft tissue management in aesthetic region and prosthetics, final prosthetics procedures. Next case, the socket preservation in aesthetic region and soft tissue management. Here we have a left centralizers. I didn't have it today. I forgot in my office, and I remember that I have a one print screen in my mobile phone. We have a, this is not typically tape 1 socket, but it is between the tape 1 and tape 2 post extraction sockets where we don't have a buckle bone. So how I started, I extracted the two. Started with the membrane application. It is shaped like the ice cream cone technique, and then I apply. I extract the third molar. From this molar, I made the autologous dentin graft, apply in the socket, and then I cover it with the membrane. Apply the connective tissue graft, triple zone technique, and apply immediately provisional. And during this phase, after this phase, I will say what's happened. Triple zone concept, application of immediately provisional. Now you see why I perform this index very simple from pattern resin. And here is the healing after 2 weeks, 4 weeks, and after 3 months. During this process, patient became pregnant, so we now waiting for implant placement, and we leave this and we will leave this on in this provisional, which is bonded with the wire for the next 7 months, and we will start after pregnancy. We will start with the implant procedures. But with soft tissue management and socket preservation technique and membrane application, because here the mostly buccal bone is missing, we get the perfect results after 3 months, and we retain the buccal volume. It is very important to perform the soft tissue procedures and prosthetic procedures simultaneously. And here is the one interesting cases. The main complaints is also this gingival pigmentation, and this should have a periapical process and should be and must be extracted due to also mobility and periapical lesion. And here is we have an implant, immediate implant placement, provisional, fabrication of provisional. As I said, it is very important to follow these rules for all these 3 zones. And we apply the connective tissue graft in these cases from tuberosity. I will explain later why I perform this from here tuberosity connective tissue graft. I apply it in a pocket which I prepared. Here is the provisional. As I said, should be properly shaped. We should create the space for a connective tissue graft. I'm shaping all my emergence profiles by hand. I don't using already fabricated provisional for laboratory, because I always need to take the final position of the implants, and I take the look what I get from the extraction socket when I extract the implant. I coronally repositioned flap, apply the sling suture, and here is the result in provisional, initial, immediately post-operative, 1 week post-operative after suture removal, and 1 month after post-operative. And here is the result 3 months after procedure. Before the final prosthetic procedure was done, we saw that we have a perfect emergence profile. Here is this zone, B zone, where I perform very big concavity, which I need for because I took very thick connective tissue graft from the tuberosity, and I need the space for this connective tissue graft. But A zone, it is retain the shape of post-extraction sockets, because it is important for a soft tissue support. And here is the one interesting case, because I also performed the soft tissue procedure on a final definitive restoration. After, when I apply the definitive restoration, I start with removing the gingival pigmentation. Why I took the connective tissue graft from a tuberosity? Because I want the hypertrophic nature of tuberosity. I need a very thick, dense connective tissue, because I need to remove this gingival pigmentation very deeply. So I need the very thick connective tissue graft. I remove it with the scalpel, then I apply collagen fleece and cover it with the tissue glue, and this is results 3 weeks after. Of course, I lose a little bit papilla because I should go very deeply, but not to the bone, not to the bone. I leave the periosteum and part of the connective tissue graft. You should complete the gingival pigmentation, and this is the results after 10 weeks. And this is the comparison before and after. I apply connective tissue graft, remove the gingival pigmentation, and also move the flap coronarily to correct this small recession. And here is the result after 1 year. And if we look very precisely, we could see this hypertrophic nature of tuberosity connective tissue graft, which also it is not so don't producing very good perfect aesthetics results as graft which is harvested from the plate. But in this case is very interesting, because I perform also soft tissue procedure on a final definitive restoration. And why I decide to perform soft tissue procedure removing gingival pigmentation on a definitive restoration? Because with the removing and application and the application these prosthetic components, we also tearing this small connection between the implant restoration and soft tissue. And if you read the studies, with repeated reconnection and connection of prosthetic components, we can also induce the loss of soft tissue, and we can also produce marginal bone loss. And here is the one case which is not so perfectly documented, because at the beginning I become very angry because I have one problem. Here is one patient who came in a my office, and she wanted to get a perfect restoration. I send it to took the RTG 3D X-ray, and on an X-ray I found the retained root from a trauma, because this girl had a very big trauma in the Alps. She fell in Alps and have a lot of scars on her face, and also broken tooth. And what I saw the periapical lesion on a canine and retained root fragment. And I sent this patient back to her general dentist, who performed the endodontic procedure. And I don't know why they decided to perform also epicotomy. And then I get the patient. Here we have a scar tissue, which is the consequence of the trauma. And after that, we also get the scar tissue from the epicotomy, which I didn't document it, but you will see during the cases, because because I was very angry, because I said here it will be very difficult to get any perfect results, because everywhere was a scar. But I started with extraction. I applied the implant. I try to make the flapless root extraction, and I success with this technique. And here is the results. I applied the immediate provisional. Here we have an absence of papilla. Of course, you can see now here the scar tissue from epicotomy. Here you can see it. Here is from trauma. We have everywhere the scar tissue. The tissue was very fibrotic and without any elasticity. And this is the results after 4 weeks. We have an absence of papilla, and then I decided to apply connective tissue graft to increase the soft tissue thickness around the canine, and to boost this missing papilla between the canine and premolar. I prepared the tunnel, applied the connective tissue graft, and get a perfect emergence profile and peri-implant tissue. And here is the final results. With soft tissue management, with application of connective tissue graft, we increase the thickness of the soft tissue. We get, I think that we get a little bit elasticity. I also advise to this patient to perform here the root coverage procedure, but we still don't perform it. And here is the final results. We get the papilla. So if we compare, we get the papilla back. We increase the soft tissue thickness around the canine, and we get the perfect aesthetic results with the proper soft tissue management and complete prosthetic procedure, which I named this concept prosthetic-driven soft tissue management concepts. And here is the one very interesting case: young patient and implants. Should we apply or not? Here we have a X-ray. We have a socket tape 2 with missing buccal bone, very big periapical lesion. I perform my standard procedure, connective tissue graft. In this case, I'll use xenograft bone material and membrane application, immediately application of provisional restoration with proper emergence profile for socket preservation. And this is the results after 8 days before surgery removal. Here is we can see the increase the volume of the application of connective tissue graft. And here is the question. This is the healing after 4 months, and here we have a result X-ray. And now is the question: should we apply the implant in patient with 23 years old or not? In my consequence, in these cases, I decide for a resin bonded bridge, because the implant placement in young patient I was delayed as long as possible. Why? Because there is the problem of vertical facial growth, which is now we have a lot of papers which presenting this problem, and this is the very difficult to correct it. So my suggestion is to place the implants after 30 years in the patient after 30 years, not before, because I thought that between the 20 and 30 years it is very intense, this vertical facial growth, and we can find our implant after a few years, 5 years. We can find our implants in infra-occlusion. So I will leave here this nice resin bonded bridge for next 10 years, and after 10 years I will decide, and maybe I will apply the implant. And I'm talking only about the implants and how is about the soft tissue management around the tooth. It is completely same. We cannot differentiate implants and tooth. The soft tissue procedure is completely same. The only difference is that we only work in a circular epithelium zone. We work only in A zone, critical zone, which is very important for a soft tissue stability, and it is very important for aesthetic, and how to place our restoration on a tooth to don't violate the biological width. Here is the implant supracrestal complex, and where is the difference? There is no difference. We work only in a zone, in aesthetic zone, when we performing the procedures, prosthetic procedures on the tooth. So we working in a critical zone, and this is the reason why is one of the major clinical complications in fixed prosthodontics is the soft tissue recession around the definitive crowns. We can find the 71% of the crowns has a soft tissue recession after 1 year. Why? Because every time when we lose or remove the cemento enamel junction, this anatomic landmark should be artificially recreated. Why? Because with this recreation of cemento enamel junction, we produce the soft tissue support. And this is the very important to prevent recession. And this also explains why this technique from Stefan Chu and Dennis Tarnow, dual zone techniques, have a perfect results. And here is the case. We have one young lady who want to replace all the metal ceramic restoration. And how I start, I remove the old prosthetic restoration, make the fine prosthetic preparation, then I perform the crown lengthening, I remove the excess, I perform the gingiectomy, and after that, very important application of provisional. And here is the case. This is the why I always relining the provisional intraorally and performing direct provisional, because with only that technique I am enabled to perform proper emergence profile in in aesthetic zone, which enable optimal soft tissue support. After that, I open the flap, I re-establish the biological width, and this provisional is also landmark for creating the biological width. With this provisional, I know how much bone I need to remove to establish the biological width. And here is the suturing immediately after crown lengthening procedure. And this is the provisional. We have a perfect soft tissue results, and then I start to perform the root coverage procedure for a correction of recession on a canine. And if you see, it is very important also for recession to remove the non-cervical non-carious cervical lesion and create artificial cemento enamel junction. I apply connective tissue graft, move the flap coronally, and here is the results. In provisional, I get a perfect results. So provisional and this connective, this cemento enamel junction landmark is a very important if we're producing the soft tissue treatment in aesthetic region, and if we want to gain perfect aesthetic results. And here is the final results. We have a very nice soft tissue, and we also cover this big recession. Here is the comparison of the case before and after, and we have a stable results. We have a follow-up of the 1 year, and I will also this spring I will also have a recall visit of this patient, and I will take the picture, and I believe that I have a still perfect results and perfect soft tissue shoe. Here is my conclusion. So it is very important that soft tissue procedures and prosthetic procedure should be performed simultaneously. So in this manner, the soft tissue should be optimally adapted and supported from immediately from the beginning of the healing, and this will be enable perfect, successful results in aesthetic region. Thank you, colleagues, for your attention. I hope you enjoyed this presentation. We have a 45 minutes. It is 45 minutes is enough to say a lot, but to present everything, I need more time. I hope you can something take to home of this from this presentation. Thank you very much, and see ya.
Yeah, for sure. Thank you, Matej. Thank you very much for your presentation. And this is a huge topic, but I believe the idea here is to give the colleagues as this small drops of very important topics, and for sure the soft tissue and aesthetic region is one of the most important topics today. And then, as I said, we know each other. We change, we are in contact several times per year, so to say, and you know so deep the topic, and as I said in the beginning, the passion that you transmit your knowledge to the colleagues. This is something unbelievable, and the very beautiful clinical case that you document is also very beautiful. So thank you very much for your presentation today, and remembering the colleagues that in fact, to learn more about the topic, we're gonna offer a course with Dr. Kulis. We have our international course catalog. It's available in our webpage, and Dr. Kulis will talk 2 days about the topic in June, 10th and 11th June in Zagreb, Croatia, in the headquarters of BEGO, Croatia. So there's going to be a course with Dr. Kulis. So it's going to be a deep approach of the topic. So yeah, you already invited. You can talk with your distributors, with the area sales manager. So yeah, it will be a pleasure to have you there. So some questions, starting first, a hello from the colleague Virendra Shukla. Virendra is our distributor in the Emirates. He was sending hello to you, Matej, and I. Hello, Virendra, so nice to have you here, my friend. Was a pity to not meet you in Dubai, but hope to see you again soon. Then Dr. Dani Zhao.
Soon in Dubai. I think I will came in Dubai in May. I will have a visit.
So we need to give you the contact of Virendra. He's a very nice guy, and I'm pretty sure he will be very glad. He's based in Abu Dhabi, but for sure he will be very glad to assist you whenever you need. Dr. Dani Zhao, please show us the cases. It was in the beginning of the presentation. I believe Dani Zhao, we were happy. Matej was showing, Dr. Kulish was showing the cases. Matej was showing the cases. So I hope you enjoyed the cases. Then Dr. Simona asked you, Matej, in the middle of the presentation, you show a premolar case with pigmentation, and she asked, how did you correct the pigmentation of the gingiva?
As I said, I excise this pigmentation with a microblade, and it is very difficult to remove it, because I use the micro elevators and scissors, and I start to very easy, very gently to excise this. It is not very difficult. You saw how I go around the pigmentation with microblade, excise, and then remove it. But removing it is quite difficult. You should be very gentle, especially first excision when you're removing from the connective tissue bed is a very difficult, because you should be very precise. And after that, I applied this collagen fleece, and cover it with the tissue glue. I use the perioacryl glue.
Thank you very much. And yeah, just
But you
give us a
very
feedback.
careful to not to touch the periosteum. You cannot go to the bone if you excise, because I measure the connective tissue graft, so I know how, and I may measure also the soft tissue before performing the extraction. So I know how thick is my soft tissue. So I excise the thickness of excision is about the 2 millimeters, not more.
Thank you very much. And Dr. Simona, please let us know if there's anything else about this topic. Dr. Vida asked, which material did you use in the deep free gingival graft case to cover the wound for better secondary healing?
I use the collagen fleece from BEGO, as I presented in a slide. This is my perfect collagen fleece. I applied it, and I always stabilize it with a suture. I use the cross meter suture, and this technique in my hands work perfect, and I don't have any complaints. I have a very good secondary intention healing. In some cases, I also perform the covering of collagen fleece with the perioacryl, but I don't like it because on this perioacryl, the debris and plaque like to accumulating more than if you stabilize the collagen fleece only with the sutures.
Okay, thank you very much. Only for the collagen fleece from BEGO, no? So the commercial name for your country, Dr. Vida, is the Naturesque Co-8P. The Naturesque Co-8P. So I hope this is also available in your country, Dr. Vida. And then comes Dr. Almeidi saying thank you so much, and also Dr. Danijal. The colleague that was asking the case then said thank you for the excellent presentation. Dr. Vida, also which type of implant do you use for immediate implant in the incisor region? She has the S line from BEGO. Probably I know the answer, but let's Matei. So which implant line from BEGO?
BEGO RS6 implants, RS6 line every time for immediate implant procedures.
So just for complementation, because she asked about the S line, which is the parallel wall. So any comparison between a parallel wall and a conical wall implant regarding these preferences?
For immediate,
could be a parallel wall.
Yes, I prefer the RS6 because have a more aggressive threads in apical regions, because with this apical more aggressive threads I get the primary stability. The STX from BEGO implant system doesn't have such aggressive thread in a last third of the implant. It is a little bit different design from the middle of the implants, and I like this conical shape, which enable me better primary stability. For a delayed implant placement, when I more prefer the STX implants. For immediate, I always go with the RS6 implants.
Thank you very much. Then the colleague, Dr. Thomas Tevaril, saying thank you very much for the good, informative webinar. And also Dr. Barjan, thank you for the presentation, doctor. I'm wondering if instead of CT graft, placing a deeper implant and a multi-unit would be also applicable.
Yes, especially right now, but this case cannot present. I now start to work especially in a premolar, more molar region with the multi-units, because from November now for BEGO implant system AR6 and S6 lines, now it is available 0-degree multi-unit, and this is the perfect solution. Why? Because with multi-unit we don't reconnect and disconnect prosthetic zone in the most critical part, I would say. Not critical part. This is the C zone, connective tissue zone, and boundary zone, where we have a junctional epithelium and connective tissue. If we repeatedly reconnecting and disconnecting prosthetic components, this could produce the soft tissue recession because we're tearing this connection, and also this can produce the marginal bone loss. So this multi-units is a perfect solution for, especially I would say, for a molar region and premolar region. But in aesthetic region, I still work more on implants directly, because this enable me to produce better emergence profile, because on a multi-unit it is a little bit more difficult to create individual impression healing abutment.
Thank you very much. I believe everything was very clear, but anyway, Dr. Tevariu, if it's any other, no, sorry, this was from other colleague. So Dr. Barjan, if there's any other remarks regarding this point, please let us know here. Then comes Dr. Thomas Tevaril, and it's about the machine you use to grind the dentin. So he wants to know the name of the machine. I believe it's the one from Daria. Yeah.
I use Cometa Bio. I like the dentin. I'm big fan of autologous bone. I a lot of harvest the autologous bone from with the trephine burr. I have one it is bone collector burr. It is very similar like trepan burr, but for these cases, for a contour grafting, for a socket preservation, I like the dentin. Why? Because dentin have a very good, it is very stable. It is more stable than an autologous bone. This is my opinion. No, it is very stable. It is a little bit slower resorbable. It is between the connective tissue graft and between the autologous bone, because xenograft it is not so resorbable material, but dentin graft, it is in the middle, and the dentin graft also have also induction instead of also conductive properties.
Very nice, thank you. So again, the name of the machine is the Cometa Bio. I don't know if it's available in your country, Dr. Tevariu. Thanks a lot for the great presentation from Dr. Sheila. And then comes Dr. Mohadam. Hi, thank you for the nice presentation. Would you please give more explanation about dual and triple zone?
Okay, dual and triple zone. Triple zone is a name for my technique. Okay, dual zone technique. It is described in a paper from Dennis Tarnow and Stefan Chu. You can Google it and you will find it. The dual zone concept of dual zone technique is very simple. You should grafting the gap. This is the technique for immediate implant placement procedures. You should grafting the gap with a slow absorbable bone substitute material like xenograft, and then you should immediately apply the provisional restoration or individual or customized healing abutment, which will completely seal the extraction socket with optimal soft tissue support. As I said, do we need the soft tissue management? We don't need it. We can perform the socket sealing with the optimal shaped provisional restoration, because the soft tissue support is the most important part of soft tissue management. But studies present that we have a more stable long-term results if we also apply the connective tissue graft. And this is the reason why I like to apply connective tissue graft, because with the application of connective tissue graft, I decrease the loss in a horizontal part, not in vertical part, but in horizontal, because vertical I prevent with the prosthetic restoration, with the support of soft tissue. And my triple zone is a name for a gap grafting with the slow absorbable bone substitute material. In my cases, I prefer dentin or xenograft material, application of connective tissue graft, and immediately apply of provisional restoration. And this triple zone technique work for a socket preservation technique and for immediate implant placement.
Thank you very much. Then getting back here to Dr. Vida, saying yes, RSX for primary stability. Thank you. Our colleague, the general manager from BEGO Iberia, Silvia Albiac, is here. Hello, Silvia. Hola, Silvia. Saying nice pictures to you, Matei. So she was congratulating you for your pictures. And also our colleague, I believe we already made a meeting together, Dr. Nina Recho from the product management department. She's the responsible for our generative materials, the Naturesca line, saying, as shown in the case, covering the donor site of a connective graft is a perfect indication for a collagen fleece like the
Yes.
Colate P.
Yes, Natrex. I like why I prefer Natrex. How you say this? Natrex.
Naturesca.
I'm little bit dyslexic, so I have a problem.
No, you can blame Dr. Nina Recho. She's online. Just kidding. So Naturesca.
I like it because it is optimal thickness of collagen fleece. It is this optimal thickness for covering the donor side, because in the most of the cases the collagen fleece is so thick, it is like the square, and this one is the perfect. So you just cut it for the size you need it. I press it with the gas, with the cotton gas. And then I slightly, my periostal elevator or any other instrument, I just put it in a physiologic solution, saline, and a little bit, how to say, mold it with this instrument, and I get a perfect adaptation. And this is the reason I like to prefer this type of collagen fleece for a covering of the donor site.
Yeah, this makes her happy. She's
very easier. It is very easy to cut because the thickness is the optimal for a covering of the donor site.
Thank you for the positive feedback. Nina and we all from BEGO, feel glad about it. Nina was also giving a smile to the MultiPlus. Of course, when we talk about the MultiPlus, and as Matei said, the concept of one abutment, one time, so to say, to avoid the trauma in the soft tissue.
This is the perfect new introduction for in BEGO implant system. I like it.
Thank you very much. Dr. Arif and then Dr. Vida saying thanking you and thank you for the nice presentation. Also Dr. Thomas Tevaril, so the colleagues that made questions. Dr. Ana Lopez from Portugal. Hola, Ana. Good afternoon. Thank you for the interesting presentation. Thank you for being here. Virendra, our colleague from the Emirates, thank you for the nice presentation. Nice explanation in a simplistic manner, beneficial to all of us. Matei is a guy that really, I don't know, he knows the topic, and he really knows how to bring these topics to the colleagues. So it's always nice to hear Matei's. Ana from Portugal has two questions. Does BEGO has already a multi-unit for unitary restorations? Maybe this I could answer. No, we still don't have, Ana. So to say, a single unit MultiPlus is something that we are in internal discussions for future product portfolio. And now I think for you, Matei, do you use always dentin instead of autogenous bone or xenographic? greetings from Portugal. So when are you using dentin? When are you using xenographic? When are you using autographic? So a little.
Very nice question, because in the next year I will prepare a lot of cases about the guided bone regeneration. Okay, autologous dentin graft I using when I have a tooth to grind it, especially if I have a third molars. I like to extract it and make the perfect connective, not connective tissue, perfect dentin graft. I like it for a socket grafting and also for a bone augmentation. But in a case of guided bone regeneration, if we have a narrow ridge, then I always also harvest the autologous bone and mix it. I like to also perform that first layer of the bone is autologous bone, and then about that I apply the mixture of the dentin graft and bone graft, dentin graft and bone autologous bone graft. This is the my mix, how I doing the bone augmentation in narrow ridge procedure. If I don't need if I don't have a dentin, if I have a vital tooth, I don't have a time to separating and removing the gutta percha from the root canals. So I don't using, then I use the autologous bone and mix it with the xenograft material, and the same technique, first layer autologous bone to the bone, and after that, about that, I apply the mixture of the xenograft material and autologous bone. In many cases, I also stabilize this graft with a fibrin sealant. I use the Berryplast fibrin sealant, but this is the topic about the bone augmentation. It is very wide topic.
Yeah.
But I think I answer on your question.
Yeah, Anna, just give us a feedback, and also thank you very much also for the multi-unit for single crown. We have colleagues also from the product management department here in the session. So yeah, based on this concept of one abutment one time, more and more for single crown or for multi cases, the idea is to avoid trauma in the soft tissue. Virendra asked you, Matej, can we make a statement that provisional abutment can reduce possible gingival recession?
Yes, of course. The immediate application of the provisional, as I said, immediate application of the provisional restoration, if we properly shaped, as I present also in a second stage procedure, if we're doing two-stage procedure, it is very important that prosthetic components which we applied when we when we manipulating with the soft tissue, it is very important that is shaped same as will be shaped the final restoration in a final volume. Any other technique that you adding the volume, the shape of the prosthetic components after healing, you will lose the height of the soft tissue. You will lose and you will increase the recession. This is the my prosthetic driven soft tissue management concept. I have a lot of cases and I get the perfect results with this technique. In immediate implant placement for a socket preservation technique, two-stage implant procedures and one-stage implant procedures. You should know that when we applying prosthetic components, the prosthetic components should be in the volume as will be the final restoration.
Thank you very much. Yeah, Nina Hecho, the colleague responsible for the regeneration materials, since delightful to see wonderful cases with the fleece. Maybe Nina, we could organize something with Matej, some for the clinical case messenger, some publication with the fleece. Matej is already gave us a case for the clinical case messenger. Maybe thinking one with the regeneration material would be great. Dr. Debbie Bosch from Holland saying hello, thanking you for the presentation. Do you think, I don't know if you have experience, Matei, but with the RI implant, our self-condensing implant, because the question from Dr. Hamid Reza, if RI implant would be suitable for immediate loading.
Oh, I don't know, because I have never been used the RE implants. I use this conventional design of implants like RS6 STX because I like the conical connection design, and I like a platform switch concept. No, so I using the only RS6 and STX implants, so I cannot answer on this concept. But if this implant is self-condensing, then I think that in a soft bone you can gain perfect primary stability with these implants. But I don't have any experience with these implants, because if I don't have a good bone density, I using the osteodensification VersaBurr. In these cases, I use a lot of VersaBurrs, a lot of implants I place today. Today I have two surgeries, both in upper jaw. All of these implants I apply with VersaBurr. And I like VersaBurr very much, and with this I get the perfect primary stability of the implants. But using VersaBurr in a thin bone, you always need to apply the veneer grafting. This is the very important.
Thank you very much. If you allow me to just jump a little, to the question of Dr. Hamid Reza. Dr. Hamid Reza, with the shape now, the RI implant is also a conical implant. Matei said very perfect, so to say. One of the beautiful things of the RI implant is that with the instruments, we have the condensers with the same shape of the implant. And so for soft tissue, it's an implant that can really reach a fantastic primary stability and also on more harder tissues, has the platform switching concept. So in fact, it could be used, or can be used. It can be used, of course, respecting all the other achievements that we need to respect in immediate implantation. So primary stability, not infection on the surgery site. So all the things that we know as professionals. But yes.
Does RE system has a guide system, not? Or
the RI system does not have a guide system. Yeah, does not have a guide system. It could be used with the pilot guiding pilot kit that we can have, but the RI system is planned for hand-free. Yeah.
Yes. Okay.
Okay. Then we have here. I just lost a little myself. Sorry about that. Just go down here a second. Okay, here DRI. You haven't used, also from Virendra, you haven't used the name laser in soft tissue surgery other than scalpel. Any specific reason that you don't use the laser therapy?
Yes, very specifically. Laser, please don't take this wrong. No, I don't like laser. Lasers is, in my opinion, is one of the biggest not good stuff in dentists. I don't know how to say correctly. Why the problem laser is because heat induction, and if you performing the gingiectomy with a laser, you will induce a lot of heat, and with this heat you will induce the soft tissue recession. This is my opinion, and this is from my head, from my hands, because I have a laser. I use it maybe 5 times. I spend a lot of money, and now I have it in a one box and don't using it, because with the laser, I have a from Sirona laser, this diode laser. You induce the heat. So this is the reason I prefer. I think that you talk about the last case which I present, tooth soft tissue management on a tooth, no teeth. So I thought you asking for a gingivectomy to perform with laser. I don't like it because this induces the heat, so you will get the recession, and I can get the precise position of the gingival margin. You will gain with the laser, but after 7-8 days, 2 weeks, 3 weeks, I found the recession, which is the consequence of heat.
Our former CEO and my friend Walter Essinger. I don't know, Matej, if you had the chance to meet Walter Essinger. He's here saying, Dr. Kulis, thank you very much for the nice presentation. Always good to see users demonstrating a very practical approach to implantology. Saying Marcel, job well done. No, thank you, Walter, for being here, my friend. Already looking forward to see you again in May in Bremen during the BIS. So thank you for being here, Walter. Dr. Ferris, thank you for the excellent webinar. See you in Zagreb. Greetings from Sarajevo in Bosnia.
You're
Dr.
welcome.
Bezic.
Yeah.
Anna from Portugal, hope to see another presentation from you with hands-on. And saying hello, cumprimentos, Dr. Marcel. Hello, Anna. I don't know, I'm not sure if this course in June that we are planning with you in Zagreb, Matej, is a 2-day. Are we planning hands-on?
Yes, we have hands-on,
okay.
And we will also we have an immediate implant placement procedure with prosthetic-driven soft tissue management. So we will learn how to shape the provisional immediately, apply on a temporary abutment for a RS6-SIX system, and we will also learn technique for connective tissue graft harvesting and application of the connective tissue graft. So complete this triple zone concept I will demonstrate, and you will also have hands-on to learn this my technique.
Fantastic. One last question is from Dr. Leon Lazic. I don't know if it's our Leon, my friend Leon. I don't know his family name. But when adding gingiva in the marginal area to correct the gingival zeniths, how long should the suspension sutures be in place?
For sutures, for 8 days, 7 to 8 days.
Okay,
not
7.
More, because then tissue start to overgrowing the sutures, and suture also produce the plaque accumulation. Some authors advise to leave the suture for 14 days. In my opinion, for soft tissue treatments in aesthetic regions, you don't need to leave the suture more than 7 and 8 days. If you're performing the guided bone regularization procedures, when you need to flap releasing, then I leave the suture for minimally 10 days to 14 days. After 14 days, in most of the cases, if I performing the guided bone regeneration, then I remove the sutures.
And I believe the next question come from Dr. Sheila. And how many days regarding of splinting?
Splinting? What splinting?
Yeah, this I don't know. I thought that would be also regarding the suture and splinting. Don't know. Maybe Sheila Dr. Sheila could be a little more specific.
Yes, could be a little bit more specified this question.
Yeah. Let's wait for 1 second, because this would be the last one. See, it's coming. But if it's not, she can also send, and I can send to Matej the question after, if you don't mind, then per email. Because with this, we are already 21 minutes after, so which is very nice, because I believe we have a very nice Q&A session, a very nice session overall. Matej, thank you very much once again.
Thank you, Master, for inviting me.
Always a pleasure. We have another projects together. Matej is going to be we're already planning Russia for the next months, and yeah, Zagreb. So as I said, it's nice to have you as a partner.
In Poland, in Krakow in September.
In Poland also, in Krakow in September. Yeah, we have some activities together planned. So thank you very much for your partnership with us, my friend.
Okay, thank you.
Thank you, everybody. So as a moderator, I finished the session. See you in the next webinar. It's going to be in March, and see you there. Bye.
See you. Bye.